So in Georgia, where I live, there's no DPC law. We got something introduced, and I actually testified in front of the Senate, and it passed unanimously in the Senate. And unfortunately, it got blown out in the lower house, and that's because of the fact that many of those legislators are being a state representative is a part-time job, and they all have day jobs. Many of them work for insurance companies, or they are brokers, or they're involved in the insurance industry, and so they're conflicted. And so it never even got out of committee in the lower house. Do you have any recommendations about how you can overcome some of those barriers?
Yeah, I mean, and in fact, sort of just anecdotally, I remember being in Virginia once where the State Insurance Association lobbyist came up to me and said, "Hey, how are you doing in Georgia and Florida?" And, meaning that, I think as Lee mentioned earlier, even though nobody testified against it, there were 200 insurance lobbyists registered to lobby against the bill. Insurers don't like what you're doing because you're essentially threatening the way they do business. So while we've seen I would guess in these 23 states, I think there have been varying degrees to how much the insurers have opposed. In some states, a few have actually supported, and then the others have sort of grumbled. Most of them stay neutral, but stab at you from the background. And some of them have been like right out in front. I mean, there was really only one. In Virginia, we had the employers, we had the employer community, we had NFIB was the co-sponsor, the lead sponsor of our bill. We had all the physicians, all the patient groups, medical schools, virtually everybody in the state against Anthem. And Anthem got the governor to veto the bill. So wasn't any surprise that Anthem was one of the largest contributors to the governor, but that helped, right? So what we did the second time around in Virginia is we sat down in front of the key sponsor of the bill with the insurance lobby. And we said, well, what do you want? What are the changes you want in the bill? And we gave them absolutely everything they wanted, because virtually everything they threw at us kind of didn't matter. They didn't really have any good arguments. So I would say, bring them into the camp and ask them exactly what they want in front of the sponsors of the bill. And as a strategy, get them on the record for what they want. They will come back and ask for more, but it's going to be very hard for the legislators after they've been through a meeting like that to be able to give them kind of what they want.
Their biggest problem is that they literally don't understand it. And because they don't understand it, they fear it. And the best way to overcome that is to educate them and contrast DPC with Concierge. Because as much as they might not like us, even when they figure out what we actually do, they hate concierge practices more. Because they view that as a form of legal balance billing, which is something they've been fighting for years. So if you draw that distinction and say, wouldn't you rather have people doing DPC than concierge, then they'll sort of back up a little bit.
And there might be a few things that you need to give in on. And I spoke to somebody today about a provision that said, well, we want to register we want you to register with the state insurance commissioner as a part of the bill. And our answer to that is, well, it's absolutely ridiculous for the state insurance commissioner to have a registry of something that they don't regulate. So, let's have a registry of all physicians with the State Board of Medicine instead. That seems like a reasonable idea, right? We call it licensure, don't we? There's answers to some of the things they throw up at you. Mm-hmm. Often they're things that are harmless, and there's a couple of things you can throw in there to make the objections go away.
Good suggestions, and I guess the take-home message would be if anybody is interested in taking up the mantle in their state, contact these gentlemen, and they'll help you. And
we have a model
develop
bill
a strategy
on the Direct Primary Care Coalition's website. So there's legislation that's been heavily vetted that is the baseline for almost all of these laws. So we can be a resource. We don't typically get really proactive, and we're not going out and looking for fights to pick in states. But when you or your state Academy of Family Physicians or your state medical society or any of your groups that you may be a part of go in to start to take on these efforts, contact us. We can provide legal resources. We can provide testimony. We can come in and on the ground testify. But it's best if it's handled by the people that are actually on the ground from the state.
Right here.
Okay, so my name is Paul Thomas. I'm a direct primary care doc in Detroit, Michigan. My question pertains to lobbying on our behalf. So I actually had a lobbyist approach me in the past month and saying, you know, would it be reasonable to have a coalition of doctors in the state with somebody kind of with an ear to the ground of what's going on in the state of Michigan, kind of keeping tabs? And I wanted to know what your thoughts were on that.
Well, that's come up before. Jeff Gold is working on is really running a Massachusetts chapter of the Direct Primary Care Coalition, and they have decided in that great laissez-faire state of Massachusetts that they actually do need to hire a lobbyist on the ground to get something done. Just sort of off the cuff, I don't know what you might want to. I know that Chad is in here and some other folks from Michigan. And we work pretty close with John Blanchard. Pat Colbeck is sort of your champion in the state Senate, and you've already passed, you've got some of the best laws in the country in terms of the DPC insurance regulation. You've also passed a provision in Michigan that urges the Michigan congressional delegation to support the HSA legislation on the federal level. And the state of Michigan is the first state in the country to pass a DPC Medicaid pilot, which is actually part of your state's budget this year. And now we're working with the state and with Pat to get that implemented at the federal level with CMS. I think you're fairly well covered right now, but if there's other threats and stuff out there, I think it's always a good idea for you all to come together, and the coalition can provide resources to help you sort of vet that and figure out what the best course of action is.
Thank you.
Great. Over here.
Thank you. My name is Carol Bridges. I'm a family physician in Montana. And yeah, I know, we're the ones that the governor vetoed our bill. My question is, interestingly, we met with the insurance commissioner, and our insurance commissioner plans to put out a memorandum basically saying, hey, we don't consider this to be insurance and we're not going to come after you. So the question is, then where is our vulnerability? Who can come after us? My other question is there a possibility that one of the insurance companies could sue us? Because there was some issues years ago with something very similar to direct primary care, and they were sued by one of the insurance companies, the Blue Cross, in fact.
Right.
And so I guess my question is, who could come after us if it's not going to be our insurance commissioner?
Okay. So in your case, it should be the insurance commissioner. There's really nobody else in government who has the job of policing insurance other than the insurance commissioner. If I recall correctly, your insurance commissioner in Montana, do you know, is that one of the 8 or 10 or so states where they're elected rather than appointed? They're appointed there? Okay, never mind that reference. But there were a few that ran for election in part based on their position on DPC, because in some states, you know, it's not been clarified yet. But if there's various model contracts out there. I have one that I give away, but there's also model languages in the Journal of Legal Medicine article. If you sort of do these things to limit your risk, the chance of them coming after you, number one, is real low, and if they do, you're going to win. But the way you search that out is you literally look at your insurance code, just like I was doing with Florida as an example. Make sure you're not insurance, and make sure there's no quirky argument that you're somehow an HMO either, and you're typically good to go from that government risk standpoint. What would the state do to you? In terms of insurance companies, the only way they have any jurisdiction over your practice whatsoever is if you signed a contract with them. Fortunately, a lot of the contracts we sign these days are with large health systems, often hospitals, and those are often based on your employee status, and they're not necessarily tailored to you, the individual. They're tailored to the entity. As you can imagine, you might work for your large hospital in town, and then maybe you moonlight in urgent care on the weekend, and you've got 2 different contracts, 2 different entities. You see a Blue Cross patient in both settings, and they both get paid different rates, and you never had anything to do with knowing what those rates were. You didn't necessarily sign a direct agreement with the insurance company. So unless you've signed one with you, the physician, with them, they should have no jurisdiction over you. Where it's been a problem in the past is when people say, oh, I'm opting out of Medicare, I'm dumping all this stuff, and then they don't pay attention to the provisions in their insurance contracts, which often have some sort of clause about a 90-day or 180-day out. And then they try and just do a lights on, lights off change, and they haven't waited long enough, haven't followed the provisions of ending that agreement, and then you give that insurance company jurisdiction to force you to keep seeing their patients that way for however long it was.
The only other thing I would address about the guidance is that's actually good news, I think, because we've gotten some favorable guidance out of a number of states, and I think if you actually count the good guidances we have, we probably are already at that tipping point of 25. We have a really good one in Massachusetts, for instance. And the only thing we'd say about that is, the next insurance commissioner can come around and write a guidance that says exactly the opposite. So even if you've got that, the idea of codifying that into state law is something that we would sort of recommend.
If you want to scare yourself on purpose, you can look at the Maryland page and look at the old guidance from their insurance commissioner. But I would argue that even if you had somebody very harsh like that, if you're careful with how you've drafted the contract, you can still win it.
Right here.
Hi, Jay, my name is Cynthia F.A.C.S. I'm a new DPC practice in Northern Kentucky next to Cincinnati. I participated in the DPC conference in D.C. this summer and went and visited Representative Massey and my legislators. I was wondering, what is the best way for us to know when the next fly-in is going to be? And
just come to the dpcare.org. We'll post it on the website. Unfortunately, because the nature of some of these, we've had a little bit of short notice for our last couple because we've tried to put a fly-in together when we know some legislation is going to be moving. So check it often. I know that website was pretty stale for a while. We're short on resources, but the website has been completely redone. It has a really nice new face on it. And we'll try to give you the lead time. I will say this, if we wind up having one before the end of the year, it will likely be between Thanksgiving and Christmas, because that will be when things are going to happen in terms of this year-end package that we might be involved in. And candidly, the only reason to have another one this year is to push that really hard if we get it. So otherwise, look forward to first quarter next year.
is there a mailing list to sign up for so you could shoot something out to contact people instead of waiting for us to check on the website?
We were doing a newsletter monthly last year. We're talking about getting that up, but if you join the coalition, you should be a part of that. And we have fairly regular updates that we send out as well. Yeah.
Thank you.
Let's
bet.
stay on that side.
I'm Minta Gold. I'm 10 months old. I know I look a lot older, but Phil, a question about Medicaid. So can you have Medicaid patients in your DPC practice?
In 48 states, the answer is yes.
Okay.
And how you go about doing that differs depending on what the state decided to do and how they interpreted the ACA. So ACA requirements indicated that you needed to sign up with Medicaid in order to continue ordering things on Medicaid patients and actually have them approved. So think referrals, labs, medications. And those same provisions said that as a state you're allowed to sign up as what I call opera status, ordering, referring, prescribing, and something else. And you can sign up just to do those things, essentially promising when you sign up that you're never going to bill. Texas is a good example of that, but there are several other states that have passed similar provisions. So the answer there, and it's hard to force this out of the Medicaid regulators because they don't have a clue until you ask this question where the answer is, but the answer there is you sign up, and you sign up as an ordering and referring only provider. And then you can still privately contract with your patients. When you send them to CVS to get a prescription, if they don't want it in your office, then they can do that and get it filled. If you're in one of the states that doesn't interpret it that way or doesn't have that status listed, then usually your best bet, or your safest bet, is to just not enroll. Because unlike Medicare, where everybody's defaulted in, with Medicaid, you're only enrolled when you raise your hand and say you want in, and you can come in or out at pretty much any time. So you just make sure you're not enrolled, and then you're free to privately contract. The known exceptions to that are Kentucky and Colorado, where they don't care. So if you had a hankering to treat Colorado Medicaid patients in a DPC fashion, come on up to Cheyenne, because they have no jurisdiction in Wyoming. But I don't have another mechanism in those two states, but just about everywhere else, there's usually some sort of solution on the books. The gray area, and I've talked about this with the Wyoming Medicaid director actually, is that some states don't have that opera status, but if you read their regs specifically, it also sounds like you could actually still go ahead and enroll in regular status and build an argument that you can still privately contract, but I'm not recommending anybody in here try that right now.
And there was rumor that if a Medicaid patient signed up with you, that they might get kicked off of Medicaid because if they had the money to join a DPC, then they probably didn't need Medicaid. Is that just
I've never seen any state that's doing
Okay.
that.
Down here?
Thank you. I am not a physician, but I am a legislator from the state of West Virginia. We just passed the law this
Wonderful.
past session. So, however, my husband is a physician in West Virginia and now started DPC in 2 locations. But my question is, as a legislator, I noticed something on one of your slides that said West Virginia was restricted. I wasn't sure something else we could be doing as a
That was-
legislature for.
That was probably one of my earlier ones.
Okay.
So they were in red initially, but you guys corrected that this past year. So there's not a major problem in West Virginia as far
So
as opening a
there's
DPC
nothing else
practice
we
at this
need to
point.
do.
But
as
again,
a
I think there's
legislature.
opportunities, looking at things you might be able to do with direct primary care with your state employees. And I don't know whether there's any peculiarities in Medicaid there that need to be smoothed over, but certainly doing something like Michigan where they actually initiated a pilot to do Medicaid in DPC.
Yeah,
would-
there are
that
some
would be
states that are pursuing it. The states have more autonomy for their own employees' health care than they do Medicaid because of the federal regulations with Medicaid. But
Right.
you can certainly try and save the state money with some sort of state employee pilot. You could even go as far as what Michigan's doing, where they're trying to pilot DPC for Medicaid patients. Make sure there's an opera status. I haven't looked into that in West Virginia specifically, so they may already have it. I don't know. And then the last thing, just because I trained in West Virginia, I did med school and law school there, so I'm very familiar with the state and I like it. But the other big issue is just the way the healthcare authority is structured. It's one of the most powerful and ominous certificate of need bodies I've seen.
We have been working on that. We have reduced that somewhat, and we actually are working to try to get rid of the certificate of need, which we may do this next session. So.
Good.
Thank you.
Certificate of need, that's something very near and dear to Docs for Patient Care's heart. We convened a conference in Washington in June on that. If anybody's interested in talking about that, please find me. I have a couple more questions before we wrap it up, if there's no other questions from the floor. What's happening in Washington right now in HHS is a little bit of a upheaval. We had a very sympathetic secretary for DPC that unfortunately is not there now. Is this something, in order to get the protection that we would like to see in Washington, that will require legislative action, which many people are skeptical will happen. Is this something that might be possible through executive action?
So are you talking about the HSA statute or?
Yes.
Yeah, so as I referenced before, we've been in to talk to the IRS, and we've been in to talk to the Treasury Department and the IRS and the Trump administration, and they feel their hands are pretty tied by at least one of the 2 pieces of the statute that get them in trouble. So we have to pass the bill. The administration at the very highest levels, is completely supportive of getting it done. The change with regard to Secretary Price has not changed a lot of staff that's working on this internally. Seema Verma is there, and as you probably remember, was also nominated separately from Secretary Price. I personally don't think that this administration is likely to try to put a nominee before the Senate for confirmation this year. So Eric Hargan, I think it was just nominated Deputy Secretary. He'll be acting for a while. He was on the transition team. He comes from a relatively free market background. I don't think we have any problems at all with the direction this administration is going in. And in fact, the good news is, even on the other side, there's a ton of interest on the Democratic side in terms of looking at what we're doing in DPC as providing, frankly, a concierge level of benefit to people of all incomes. So I don't feel like we're in any kind of political risk because there's turmoil in the Department of HHS right now. But we're quite the opposite. We're on a significant upswing because I really do think they see not just DPC, but the entire free market medical movement as the core of the policy change that they want to make in Washington.
Okay, here's another question from the floor.
I'm going to try and phrase this in a way that makes sense. So if it doesn't make sense, ask me to clarify. This is for Jay. Contrasting or sort of comparing our keynote speaker, Doug Farrago, over the lunch hour with what you're saying and some of the research you're bringing forth with the DPC coalition. You highlighted some data and some programs, some initiatives in New Jersey with IORA and Our Health, kind of all over the place. Because one of the key points that he had made was sort of, is he in here? I don't know if I'm going to get the boop right. Remove government, remove insurance, boop, I believe is the exact quote.
It was boop.
Boop, was it higher? Okay. You can always ask me to clarify if this isn't making sense. How do you, especially with Hugh Lyons' outcome, how do you anticipate what you're going to get from some of these initiatives that you're actively working on, that you're highlighting, that you're kind of raising up and saying, look at this data that we get, look at what we're doing, and kind of some of the underground movements of, removing those players from the equation. I just kind of want to hear you talk about that. That's not a question, but go.
No, I think it's a great question. Well, number one, because I'm a badass. We're going to make sure that it's all good. No, just kidding. Look, I mean, we would all like there to be no insurance companies and no government. We like ponies and unicorns at our birthday party, too. It is a fact of life. The rationale behind our coalition is that we are doing what we can to work within the framework that's there and political reality to get things done that are going to make DPC grow. The beautiful thing about what's happening at Medicare, for instance, right now with this pilot, is that there is absolutely no conversation about mandating that you participate in Medicare. If there's a DPC Medicare pilot, or if there's a DPC state employees pilot and you don't want to participate in it, you don't have to participate in it. So I think laying options on the table and also knowing one of the things he was saying is that this is hard. It's not for everybody. There's going to be Medicare Advantage. There's going to be patient-centered medical homes. There's going to be ACOs. There's going to be other ways of doing primary care that are out there. So our guiding philosophy is to try to get laws passed that help enable you to do what you do the way you want to do it, and not put too many restrictions around that, but to go to payers like the government and say, look, why don't you pay the DPC guys their fee? That would be a really great way to go. Or why don't you pay the beneficiaries to pay the DPC guys their fee? So these are all things that I think we're trying to get our arms around, but understand we're not going to be able to create a perfect universe where you can do everything you want without anybody watching over you. Does that make any sense?
It did. So you mentioned earlier that the state insurance commissioners are a roadblock. If you've got a state insurance commissioner that's just impossible to get by, is there any other recourse? Can you go to the Attorney General?
I've not taken that political approach. I've had several one-on-one meetings with different state insurance commissioners, and it's just a matter of usually just educational. And that's part of the reason I had that piece published in Journal of Legal Medicine, because it's not precedent the way a judicial case would be. There's really none to refer to here. But it does compare a bunch of different state and federal laws and offers good guidance on it. So places where I've had a barrier, I don't know if I should name states by name, but
Oh, go ahead.
Go ahead. I mean, there are some, Kentucky, West Virginia, it went really well. Wyoming, it went really well. So I would, first there were questions that were raised and we had a conversation.
Massachusetts, it went really well. So you really can never tell.
And you exchange the information and it goes great. Other places, South Carolina, it didn't seem to matter that we had that conversation. Either people didn't like it or didn't read it or what have you, but every state reacts to it differently. But with insurance commissioner's office, you want to get them one-on-one or whatever. You don't want Blue Cross or Anthem or whoever in the room with you there. That needs to be a separate discussion. And if they're on the same side and both sort of polluting the room with misinformation at the same time that you can't overcome, then that's a problem. Because their reasons for not liking what we're trying to do are very, very different. The insurance commissioner's office is usually because they don't understand the how we don't take on risk. They don't understand that our scope is narrow, that we're seeing 600 to 1,000 patients and not 50,000 patients or some ridiculous number. And insurance companies don't like it because they think it's the same thing as concierge and they think they're being cut out.